my co-moderator, Dr. Pahlajani, is going to talk to us and tell us which antiplatelet therapy should we be using.
Good morning, ladies and gentlemen. First of all, let me congratulate Dr. Srinivas Kumar for a wonderful organization, and I think the communication, the arrangements, and the choice of topics has been simply superb to induct the people into the advanced stages of angioplasties that they have been doing. And he has given me a topic which because I didn't want to appear as a kind of a guy who should be promoting a particular brand or particular antiplatelet agent, but I will show you some slides and some presentation to show you why we should pick up a particular dual antiplatelet therapy for a patient who undergoes PCI. As a matter of fact, dual antiplatelet therapy has become a standard of care for any patient who undergoes PCI. And this has been going on for last more than 15 years since the publication of PCI Cure and the PCI Clarity trials, in which patients were randomized to receive aspirin plus placebo, and on the other side, aspirin plus clopidogrel. And you can see this cardiovascular death, myocardial infarction, and urgent revascularization was lower in the patient's group that received aspirin plus clopidogrel. And since then, we have choice available because there were some issues concerning clopidogrel that we'll discuss a little later on. Aspirin monotherapy is totally out of question for any patient who undergoes PCI. In the dual antiplatelet therapy today, you have got a choice of using aspirin plus clopidogrel standard dose, aspirin plus clopidogrel double dose, aspirin plus Prasugrel, aspirin plus Ticagrelor, and also there's a Korean data available which recommends in certain subset of patients triple antiplatelet therapy by adding celestazole. And as all of you know, Ticagrelor came as an IV drug to be given in the cath lab when you want to be used, patients to be taken up for an emergency angioplasty. However, the champion trial proved to be negative, so we will not talk much about it. The issues with clopidogrel therapy are many. As a matter of fact, the most important one being the clopidogrel resistance and the slow response. The second thing is the dose. What should be the ideal dose? Should it be 300 milligrams? Should it be 600 milligrams? Or should it be 900 milligrams? And a lot of confusion took place about 4 or 5 years back on the use of proton pump inhibitors along with clopidogrel, especially the omeprazole. We'll talk something about that too. And of course, all of you know about the CYP2C19 polymorphism, in which if there is a deficient allele, clopidogrel acts very much less than what it should act otherwise. Now look at the clopidogrel resistance. As a matter of fact, clopidogrel resistance has been found to be time bound in 2 hours, 24 hours, 5 days, 30 days. As the days pass by or the hours pass by, the resistance goes on reducing. However, in the first 2 hours is 63%. And this is the time when you want the maximum antiplatelet drug therapy to act to cause platelet inhibition. And therefore, if you have a patient who has got an acute coronary syndrome, acute myocardial infarction, who has neither been on aspirin before, not on clopidogrel, there you want a drug which should act immediately. So I think there's a very important issue with clopidogrel. The second issue is with the dose. If you see the dose response to 300 milligrams and 600 milligrams, if you give 300 milligrams, close to 28% patients will be hyporesponsive. So therefore, in the cath lab, if you give a 300 milligrams as the loading dose, about 28% patients will not act adequately, will not have an adequate action. So therefore, you are really not achieving an adequate antiplatelet effect. What about the 600 milligrams and the 900 milligrams? Yes, it appears that the 600 milligrams seems to be quite an adequate dose, because if you compare 600, 900 and 300 milligrams, you find that the 900 milligram dose is no good, no better than 600 milligrams. You achieve an adequate antiplatelet effect with a 600 milligram therapy, so there is no need to increase it to 900 milligrams. But certainly 300 milligrams, what we have been using in the past, is not the correct dose to be given to the patients who undergo PCI. And to substantiate that, there is a study called as current study, which is OASIS 7 study, in which 25,000 plus patients of acute coronary syndrome with unstable angina, non-STEMI and STEMI, close to 30% patients were STEMI, who were randomized to receive either 600 milligrams or 300 milligrams of loading dose of clopidogrel. And then clopidogrel was given in double dose, 75 milligrams BID for next 7 days. Along with, this was actually a factorial design, 2:2 factorial design, in which patients were also randomized to low dose aspirin versus the high dose aspirin. We'll not talk much about the aspirin, but let's see how does 360 and 600 milligrams clopidogrel work. If you find the stent thrombosis, myocardial infarction or thrombosis, cardiovascular death, myocardial infarction and stroke, it's much less than in the patients who received a double dose clopidogrel. So it appears that even in the clinical setting, when your patients have acute coronary syndrome, the double dose clopidogrel should be the ideal dose. And this became more evident in the group of patients, about 30% patients were STEMI patients. You find that all these endpoints were better in the patients who received double dose clopidogrel. What about the confusion on the proton pump inhibitor? There was no question. There were lot of trials, lot of articles which appeared about 5-7 years back, which said that if you gave omeprazole to patients who received the clopidogrel, the platelet inhibition was reduced with the use of omeprazole. So they said that if you use pantoprazole, it will disturb the antiplatelet effect of the clopidogrel much less than omeprazole. And if you can see here, the platelet inhibition was much less disturbed when you gave pantoprazole and compared with omeprazole. However, there was a trial by Dr. Deepak Bhatt and his associates, and they found that when they randomized their patients to clopidogrel plus aspirin plus omeprazole versus dual antiplatelet with placebo, there was no difference in clinical cardiovascular endpoints like death and myocardial infarction. However, this confusion has been further compounded. If you go through the net now, this is just an article which just appeared on the net just about a week back, and that has come back again to put some kind of a doubt on the proton pump inhibitors, and that actually says that the pantoprazole significantly interferes with the antiplatelet effect of clopidogrel. What about the CYP2C19 reduced function allele carrier state? And if you see patients who are allele carriers, amongst them the cardiovascular death, non-fatal myocardial infarction and stroke is higher as compared to the patients who are non-carriers. Now there are kits available where you can sort of find out the patient is a carrier or not a carrier. So therefore, to overcome this, we have a new drug, or actually not absolutely new drug, a drug which has been on the block for last 2-3 years, Prasugrel, which is a third generation novel thienopyridine. It's a prodrug. It needs to be actively metabolized. Then inhibits ADP-induced platelet aggregation. The beauty of this is that it is more rapid, much more rapid and more consistent and greater platelet inhibition. You all are aware of this Triton-TIMI 38 trial, 13,000 patients randomized to clopidogrel, standard dose and Prasugrel. And what you find, cardiovascular death, myocardial infarction and stroke was much lower in the Prasugrel arm as compared to the clopidogrel standard dose arm. However, this came with a small price that the bleeding rates were higher in the patients who received Prasugrel. Stent thrombosis also was lower, whether it was a drug-eluting stent or a bare metal stent. The stent thrombosis rates were lower in the Prasugrel arm. And especially in the diabetic subgroup, the Prasugrel worked better as compared to the standard dose clopidogrel. And again, in the CYP2C19 reduced function allele carrier state, Prasugrel did not have any differentiation on carrier or non-carrier state. So therefore, even if your patient is a carrier, the Prasugrel will act much more better than the clopidogrel. However, there were certain caveats that if your patient had a prior stroke, TIA, age more than 75 and less than 60 kilograms weight, the Prasugrel had some disadvantages because in a patient who has a prior stroke, the Prasugrel did not work. How about testing it against the 600 milligram dose of clopidogrel? Even Prasugrel 60 milligrams loading dose proved to be better than the clopidogrel 600 milligram loading dose. So it appears the Prasugrel is a better drug. What about the latest drug which is not still available in our country, Ticagrelor? First of all, you must know that Ticagrelor is a direct acting. It is not a prodrug. It does not need to be metabolized in the body. Its action is very rapid. It has got a greater inhibition of platelet aggregation than clopidogrel, and it is reversibly bound and it can be easily reversed. All of you are aware or heard about Plateau invasive trial in which 13,000 patients were randomized to clopidogrel and Ticagrelor, and you find that the Ticagrelor arm patients did better when it came to cardiovascular death, myocardial infarction or stroke as compared to the clopidogrel. As a matter of fact, if you look at the platelet inhibition with 600 milligrams of clopidogrel loading dose, even when Ticagrelor was compared with that, Ticagrelor proved to be better on a 600 milligram loading dose also. So therefore, we select the appropriate antiplatelet drug on several clinical considerations, whether it's a planned or acute, age more than 75 years, weight, TI, stroke, diabetes, polymorphism, allergy, thrombus burden, DAPT versus CAPT. At the moment, what I've shown you, it seems that the current evidence suggests that if once Ticagrelor is available, it should be a first choice antiplatelet drug. Otherwise, clopidogrel, one always must use 600 milligram loading dose and can be given in patients who got TI, stroke, the weight less than 60 kilograms and older patients. And Prasugrel, I think I will not use in patients who have got a TI or stroke, but it will be a drug of choice, patients who are high risk acute coronary syndrome, STEMI or a large thrombus burden, diabetics, and patients who are more than 60 kilograms and in whom I know there is a CYP2C19 deficient allele. Thank you very much.